100 femoral neck fractures treated with screws, you will find perhaps 3 or 4 with ideal position of the screws. So why do we use screws when we have such a small number of excellent positioning? Why don't we go directly for what is iatrogenic? What are we doing and what is really a complication? I am in this medical legal problem since more than 30 years, and it is really very difficult to say this is a mistake and this is borderline and this is not a mistake. It's very difficult because, of course, we want to protect a little bit each other. We cannot blame every orthopedic surgeon when he fails from time to time. So, but here it's clear, you see, this fracture, obviously the surgeon did not realize the dynamics in this injury. It's a very critical fracture which runs up here, and this you cannot stabilize with screws. This will never be stable enough in this fracture. And if you do your corrections like this, put your blade into the hole and over the hole, then you should not be surprised when you end up with a catastrophe. That is, I collected this data about 5 years ago. I think it has not changed very much. The treatment of neck fractures is dynamic osteosynthesis, hernia prosthesis, total prosthesis, screw fixation, conservative. So already 42% of the problems of femoral neck fractures are taken away by the arthroplastic surgeons. So we, the reconstructive surgeons, have only 60% to deal with. Maybe good or maybe bad, I don't know, because also with these implants, with these arthroplasties, we get a series of major complications. What has become clear over the period of time is that reduction is utmost important. That was said by Pradhan very clearly. Reduction and a careful reduction. You should not turn around the head once or twice in rotation. A careful reduction. And for a careful reduction, I still feel the operation on a normal table is more careful than on a traction table. And second is, when we do the classical reduction maneuvers of Ledbetter or whatever, the simple reduction maneuvers, pull, flex, rotate internally, abduct, and put the leg down. Usually it is reduced. If not, you can try it a second time, but then you open up and reduce it carefully with the joystick. So, good reduction and then a solid implant, whatever it is. I think that 2 screws is not solid. They have not grip enough. Either a DHS or I still prefer this blade, this 130-degree blade, fixing it here with 1 screw only, an additional leg screw when it is a HOLZ 2 or 3. Screws alone as implant needs strong bone quality. So in young people, 2 or 3 screws may be good. But in elderly, let's say 40, 50, 60, 70, I would choose a DHS for such an implant. And if you manage to get this reduction, this position of the implant, you can be 95% sure that it will heal. The only problem is necrosis. Avascular necrosis, this is not in your hands. We are happy to see Professor Laut. And the important thing is that you don't do any rotation and you keep the fracture plane not in a steep one. You have to transfer it to a horizontal one. Let's come back to this case. What shall we do? It's a clear non-union and it will not heal. You can wait another few months. The solution is always the same. As long as the head is alive, you do a valgus osteotomy. I come to that back later. What is important to prevent these failures which you have seen? You must be aware of the good reduction, and often in HOLZ 3 you better do an overcorrection into valgus. you should be aware of the dorsal defects in the neck. If there are these dorsal defects, screws will fail. You need a stronger implant. You have to use a DHS or an angle stable plate. And sometimes a primary valgus osteotomy is good. When there is a failure of osteosynthesis, you have to make sure that the head is vital. If the head is not vital, you straight go for a replacement. If the head is alive, you always should go for reconstruction, which is some kind of valgus osteotomy. And if you have a necrosis, then you do any kind of a replacement, whatever you are used to. This is a case recently done. Sorry. The fellow came with pain, and you see that is not reduction. The fracture line is still very steep. It's a Powell 3 line. The screws are not good enough, and especially the head is rotated. So you can wait months, it will never heal. So the solution is transpone the fracture line into a more horizontal one, not completely horizontal, you can't do that, because that's too much valgus, but about 30 degrees, and in the axial view, in the Lauenstein view, you have to reconstruct it properly, and then you do the intertrochanteric osteotomy, that is here, the line. I cut through, transverse, and then I impact the proximal fragment into the distal fragment, so it gives rotational stability. Simple, straightforward, very easy. And this is after 8 weeks. No necrosis, the fellow is not yet necrosis, the fellow is walking on it, full weight bearing, free function. So this is the best way out if you have a failure after any kind of osteosynthesis of a neck fracture. And this procedure has stood the test of time since many, many, many years. I think this was one of my first one in 74 with the valgus osteotomy, and 77 you see congruity of the joint, head alive. Again, such a case with screws. You see, I will not blame the screws. We have first blamed the surgeon because he did not reduce. This is not reduction. This is not reduction. Posterior dislocation. And if you have this, you, as soon as you recognize it, take off the implants, go for a valgus osteotomy, and avoid to shift the shaft too much medially. Too much valgus will create problems in the knee later on. So do a decent valgus osteotomy and take care that you have the axial view deadlined. Lauenstein view must be perfect. Then the chance for healing is very good. The approach is a Smith-Peterson, is a Watson-Jones approach. Very easy, open the capsule, manipulate the head with a joystick into the proper position, and that's it. And then the valgus osteotomy, the procedure is done. You take a fixed angle, double angle, 120 degrees. You want a valgusation of 30 degrees. That means you hammer in your chisel and your plate perpendicular to the shaft. At the end, the plate will stand away from the shaft 30 degrees. Then you make your cut. You may take outer wedge or not necessary. Abduct the leg, abduct the femur, and fix it with screws. That's all. And take care, after having cut the osteotomy, that you don't get rotation. Very important that the knee, the patella, is looking to the ceiling, and do it on an ordinary table. Put the patient straight on an ordinary table. See, if you want to do more, then you have to come from above. Then you can do 50 other signs of vitality, you know. In an ordinary X-ray after 4 years, is that head vital or is it dead? What are
and improves the hold in the femoral head, reducing the chance of cutout. This goes in by compaction, whereas in a screw you need to tap it. This you hammer it, so it compacts into the bone. increases supportive surface area, thus less chance of cutout. Now for the reaming of the plate, now what's the difference in this technique of this procedure? The reamer is slightly different. I'll show you the comparison. The reamer is slightly different. It has a small, it doesn't have a long reaming arm, whereas in a normal screw, this is the reamer. This is the reamer for the DHS blade, and you hammer it inside so as to compact and rather tap, and you normally screw the DHS screw, whereas the plate you have to hammer it inside. I'll show you a few cases. This is an 87-year-old female with unstable hip fracture, a DHS blade with an LCP DHS, and with the blade you also have a LCP DHS plate, a barrel plate, wherein you can put locking head screws because it's from the next day. In stable fractures, weight bearing you can start within first week. If your reduction is proper, you have achieved good reduction and a good stable strong implant, you can start weight bearing within the first week. In unstable fractures, non-weight bearing walking with help of walker in 2-3 days. If the patient can do non-weight bearing, if the patient cannot, because a lot of these patients are old, they really don't understand how to non-weight bear, so it is better not to walk them at all than to make them non-weight, start them with non-weight bearing, and at the end of the day you understand that they are bearing weight on that leg. And weight bearing usually after 4 weeks you can start in such cases. In nailing cases, of course, you can start weight bearing early within the first 10 days. To conclude, stable fractures should be treated with a dynamic device and DHS is preferred. In unstable fractures, intramedullary as well as extramedullary devices can be used. Fracture reduction is of prime importance. Again, at the cost of reputation, fracture reduction is what is which is of utmost importance in these cases. And accurate positioning of the implant is also important.